When the world has got you down. And
Alzheimer's sucks. It's an equal opportunity disease that chips away at everything we hold dear. And to date, there's no cure. So until there is, we continue to fight with the most powerful tool in our arsenal, love. This is Love Conquers Alls, a real and really positive podcast that takes a deep dive into everything Alzheimer's, the good, the bad, and everything in between. And now, here's your hosts, Susie Singer-Carter and Cassie Cruz.
all you gotta do is sing a song.
Welcome. I'm Cassie Cruz.
And I'm Susie Singer-Carter, and this is Love Conquers Alls. We are the podcast that takes a deep dive into everything Alzheimer's.
We keep it real and really positive, sharing fears, feelings, and frustrations,
And the latest news and resources and fabulous guests.
like the one we have today.
Yes,
Susie,
yes.
please tell us all about him.
Our guest today is an amazing, wonderful human being named Dr. Ted Etling, who is the Director of Neuropsychology and Cognitive Rehabilitation at the Arizona Neurology Associates. Is that correct, Ted?
That is correct.
Yay. Phew. That's a lot of words in the morning.
It sure is.
And the cool thing about Ted is that he is now focused primarily on Alzheimer's and dementia. So we're really lucky to have him as a guest.
And you're a Buckeye fan, so we're all winners on that.
I
one.
know.
We're really, really excited to hear about neuropsychology.
That's my first question.
So neuropsychology is actually a very small field, and we basically practice neurology the way it would have been practiced many, many decades ago. A lot of people don't realize we haven't had MRIs and CAT scans until the 70s. So it was difficult to look underneath the skull and see what was going on. A lot of neurologists in the old days would have to do cognitive testing to determine, A, is there a problem? B, where is that problem probably located? So that's what I do, is I do a lot of cognitive testing that checks ability to pay attention, ability to remember information, visual perception, expressive language, comprehension, as well as executive functioning, which is your ability to problem solve, use a strategy to solve a problem, flexibility in your thinking, reasoning, judgment, things of like that.
Can you dive into what that means a little bit when compared to a healthy brain and one that might have dementia or waning in that way?
Sure. So all of these functions, just like physically, unfortunately, we change. It's a little bit of a downward trend as we go along in life and get older. Same thing with cognitive skills. There's going to be a decline, but there's a decline that's normal for someone's age and education level. And then there's a decline that might be beyond that. And it's when we start seeing decline in memory and some of these other functions that I mentioned is when we start to realize we may have dementia on our hands. And then we try to figure out what type.
And everything's on a spectrum. And so you can't just look at data always.
Right.
To identify
and you're exactly right. I mean, in terms of if imaging could tell us if someone has Alzheimer's or not, you wouldn't really need me. Especially in the early to mid stages, imaging really isn't going to tell you very much. And even if it did, even if there was a lot of atrophy to the brain or some abnormalities, it's still not going to tell you how that has impacted the person's functioning. Because I've seen people with areas of atrophy that handle memory, yet somehow or another, they're remembering a lot of information, an appropriate amount. And it just means that some other area of their brain has started to compensate for some reason. So even though we have the ability to look at physical changes in the brain, and that's what an MRI is for, it's still not going to tell you how that change is impacting that person from their ability to remember information, problem solve, things like that.
So how is Alzheimer's really diagnosed? What is that process?
So normally someone will go into make an appointment with their primary care physician. They end up mentioning that I've been forgetting a lot of information, or often it's the person's spouse or adult children that are there at the appointment who are mentioning it. And then they get referred to a neurologist. The same story happens again. They'll do sort of a neurological exam. They'll even do a very brief version of what I do, which is called the mini mental status exam. They'll give them 3 words to remember. They'll ask them to spell a word backwards and do different things like that. It takes about 5 minutes. Just a little screener to see if there's anything to worry about. But in the end, they'll end up sending them to me, as well as sending them for MRIs, CAT scans, because you want to rule out, has there been a stroke that we didn't notice? Send them for EEGs to make sure that they aren't having seizure activity that they're not aware of, things like that. But in the end, they'll come to me where I do the testing and determine, is this memory loss or other changes in those other domains that I mentioned earlier? Are these inappropriate for their age, or are they age appropriate?
I've heard that it's very difficult to actually diagnose Alzheimer's.
So dementia is sort of an umbrella term for a lot of different kinds of dementias. Alzheimer's makes up the majority of the dementias. It makes up about 65-70% is sort of the estimate. There are even some different variants of Alzheimer's as well that are pretty rare. But the other 30% tend to be made up of vascular dementia. This is a degradation in thinking skills that's due to strokes, transient ischemic attacks or mini strokes. A lot of little vascular things that are going on. Lewy bodies, which has a lot of motor issues. It looks a lot like Parkinson's at first. And frontal temporal dementia, which tends to start with a lot of behavioral personality changes, lots of difficulties finding words and language issues, and the executive functioning issues with they just aren't able to organize their day and plan and problem solve and things like that.
The second most popular one that you hear about a lot is the Lewy body,
Right.
and it seems to manifest. Am I wrong? In a much more rapid pace.
I've never even heard of it. Wow.
So Lewy bodies is very difficult to treat. It does have a faster course than Alzheimer's, and it's really kind of particularly nasty. It tends to start a lot with some visual hallucinations, and they can be very detailed, and it can be very disturbing for the patient and their family. They're seeing bugs crawling on the walls, animals on the floor, people, sometimes families, sometimes they're family that are past, and sometimes it's strangers. There's some sleep disruptive behaviors we call REM, sleep disruptive behaviors, where they have very vivid dreams and they'll get up and reenact the dreams. As they may think someone's at the door, they'll get up and answer the door. They may think someone's in the house and feel paranoid and go get the gun, walk around the house, things like of that nature. But they also have some cognitive decline as well. But there's usually some Parkinsonian type of tremors or shuffling gait like you would see with Parkinson's. It's hard to tell the two apart sometimes because Parkinson's patients can also develop a type of dementia that's different from Lewy bodies.
Right. Yeah, you see a lot of athletes.
That's what we saw with Muhammad Ali and things like that. Yeah, most likely all the jarring to the head caused some of these things. Sure.
Can I still be confused about how you diagnose Alzheimer's? I'm
Yes.
sorry. I'm
please.
confused about it still. I don't know if I really. I know you said a whole bunch of answers, but can you distill it a little bit more for us dummies over here?
So let me give you some more something more specific to hold on to. So with attention concentration. Now, I normally have an assistant that does all the actual testing. I decide which ones to give, and then I hand them off to my assistant who does 2.5 hours of testing. They're called a psychometrist. They're trained in administering the tests. But they might do something like give you some digits like 917, and you just say them back, 917. And then it'll get longer, like 6849. 6849, and then it'll get longer to 5 digits, 6 digits, 7. We see how far you can go, and then we change it, and we say now we're going to say digits and you're going to say them backwards to me. So 917, they'd have to say 719, and we get to 4 digits, 5 digits. That's an attention concentration type task. In the middle of all that, we may give you 12 words to remember, and then we'll rehearse them with you 3 times. And then 20 minutes later, say, now we rehearsed some words a little earlier. How many do you remember? We'll read a couple short paragraph stories with a lot of details in it and see how much of it you remember later on and everything.
Right.
So, you know, after the testing, they'll end up going back to the neurologist who's really going to talk to them about treatment options. Most of the time, the first go-to is called Aricept, or donepezil is another word for it. More in the more moderate stages, Namenda or memantine is another name for it. And there's some that Namzaric is sort of a combination, and there's a few others as well. They are supposed to slow down the progression of it. I've seen it work in people. I've seen it not work in people. I've seen it work for a short period of time. I've seen it work for a very long time. So it kind of runs the gamut. I don't know how effective they are. I mean, I've seen it work pretty well at times, but now there's still some other medications they're looking at, but, you know, it's a long process to get something approved. They're looking at medications that reduce inflammation. And some of those are, I think, cancer-fighting type drugs, or they're used for other things, and they're finding there may be a benefit. But interestingly, just in the past month, I read an article, I think it was out at West Virginia, the university out there, where they used ultrasound directed at the plaques in the brain to bombard them and dislodge them. And the person had more verbal fluency. Their language got better the very next day. And
Wow.
they're slated for more of these ultrasound treatments. So there's some things they're trying. When I counsel with the people after I give them the news, I talk to them about exercise, the absolute best thing you can do for your brain. Vitamins B12 and D are very good for the brain. If they're drinking a lot, that'll reduce some of the vitamin B.
You mean drinking out? You mean drinking alcohol?
Yeah.
Because you want people to drink water.
Right. So some of them are drinking so heavy that it reduces vitamin B levels and things like that. But also the Mediterranean diet is getting a lot of notice in terms of people that have very steep memory decline, changing to the diet, which is just less animal fat, more vegetables and fruits. A lot of the things we've always been told, less red meat. The exercise, the vitamins, and the diet tends to help. So it would, and I may be biased, but I think even the neurologists that I work with would agree with me that the testing that I do is probably the number one thing that they're looking at, because if I give someone 12 words to remember and we've rehearsed them 3 times and they don't remember any of them 20 minutes later, we know we've got a problem there. But normally it's not just memory. Usually there's one other domain. So what we're looking for to make a diagnosis is memory impaired, and is executive functioning or language, or all 3 of them impaired? If so, we've got a dementia on our hands, and then it's sort of a process of elimination. Is there any stroke activity or history in their medical records? No. Is there a brain tumor, or has there been an aneurysm or anything like this? No. The EEGs, are they clear? Is there a lot of seizure activity? Things of that nature. Even the lab test, is there a B12 deficiency or D? We even screen for depression, because some people that are severely depressed, a lot of their cognitive functions will end up being depressed as well. So it's really, I think, the neuropsychological evaluation results in combination with all the medical testing that rules out any other reason. If there's no other reason, such as a stroke or head injuries or seizures and things of this nature, we're probably talking about dementia then.
Although those other things can all cause dementia.
Sure.
In some circumstances, there's fluid on the brain that can be drained, and then those manifestations leave. And
So, yeah, you're referring to what we call normal pressure hydrocephalus.
exactly, that was the words I was thinking of.
I knew you were.
Could you say those words again, though, Ted?
Yeah, I knew you were. I was just showing off, So. Yeah, so we call it NPH, or normal pressure hydrocephalus. The normal kind of word kind of throws people off. It's not normal, actually. But this is where, the brain is cushioned by cerebral spinal fluid, and there's ventricles, or there's these sort of aqueducts inside the brain that hold fluid too, and they serve to protect the brain from any jarring and things like that. But sometimes we're accumulating too much, and so the ventricles will be enlarged, and so it's what you kind of hear from lay people. You'd hear water on the brain would be another word for it, I guess. This can cause, usually the trifecta is there's gait issues, so they'll feel unsteady, so their gait gets very wide, and they have urinary incontinence, as well as memory loss and some other cognitive issues too. Now that can be diagnosed. Now that definitely can be diagnosed with an MRI. It's really the only way to tell. A certain kind of an MRI called a Cineflow, which is able to specifically tell you if there's NPH or not. If there is, they can put a shunt in, which drains that excess fluid continually off into your belly so that you can absorb it and get rid of it normally and everything. If NPH has not been present for too long, yes, your cognitive skills should return. If it's there too long and nobody does anything about it for a long time, it could cause some permanent damage for sure.
That's so important, because I know my mom was tested for that, and I know obviously she did not have that. She has Alzheimer's, However, I do know a few other friends whose parents had that and were, delighted in a way, because their cognitive deficiency turned around. And I think if you have a parent and who's displaying those kinds of manifestations, then you should have everything checked, like you said.
Yeah, the whole workup is really needed to help. It helps me to look at all those other tests to say, I don't have anything else here I can blame it on, short of doing an autopsy someday. The only thing I can say is this is probably Alzheimer's. So
What do you mean by that? Like, so it's not an easy thing to diagnose.
Right. I mean, most of the time, the most definitive way is if they did an autopsy and opened up the skull and were able to identify plaques in the brain and things like that. Typically, by the time you get to that point, it's very obvious, and you don't need to do that. So,
right. Ted, are there any drugs that you know of that exacerbate the oncoming of Alzheimer's?
Not that I know of, although there's been some research talking about some of the gastro type medications that with, acid reflux and things like that there's some studies suggesting that it may be blocking some chemicals in the brain and causing some dementia issues, but I don't know I don't think anybody's really settled on that yet, but I know there's. Are you
talking like a Prilosec or Zantac kind of thing? Those kinds of drugs?
Right. Yeah. Omeprazole, I think, and things like that. Yeah.
That of course, I want to just say this just because in case someone's taking it out there. I mean, that would probably be on a long-term basis.
And with most medical issues, and I think probably that we're going to find out this is probably true with Alzheimer's. I don't think there's one thing that's causing it. I think there's probably multiple things, and that makes it difficult to identify, and also makes it difficult to treat if you don't know exactly what's making this happen.
You've mentioned plaque quite a few times in the brain, or on the brain, or however that's stated.
Right.
Could you discuss that a little more?
So the amyloid plaques, amyloid is a protein found in the brain, and there's an abnormal accumulation of it for some reason. I don't think we really know why, but what it does, so neurons or brain cells are kind of like strands that end and have a gap called a synapse, and then the next strand begins. And what happens is information will travel through a neuron, and drops information into that synapse, that cleft, and then the next neuron picks it up. Anything we're doing, that's happening billions of times, and so the plaques are building up in that cleft, in that synapse, and preventing information from going from one neuron onto the next.
I always think of it as like a brain cholesterol. And and because it's similar to cholesterol buildup where it's blocking the transference, right? Of whether it's oxygen or blood. And in this case, it's information.
Right. It would be normally a neurochemical. With dementia, you've got these proteins that are building up in that cleft and really causing a lot of problems.
I was so fascinated by the story that I saw on the special in 2020 where there were a father and son who were neurosurgeons. The father had a stroke and lost his ability to walk, and the son did an experiment sort of reteaching his father as you would an infant how to walk.
Correct. Yeah.
And it worked. So I'm wondering if there's any possibility of that within our brains.
I'm familiar with that case. I actually read about it in a book where he was a professor, if I remember, and had a major stroke. His son, the only thing he could think of from a developmental type of a perspective, I'll treat him like he's a baby. He's going to have to crawl first. He's going to have to sit up. Then he's going to have to learn to stand and then take his first steps. The neighbors thought he was being very mean to his dad, but he actually got his dad to a point where he was able to go back to teaching again. He died 3 or 4 years later. When they did an autopsy on him, apparently more than 90% of the nerve fibers that handle movement were destroyed. So off very few nerve fibers that were still alive after this major stroke, they were able to get him functional again. So
he crawled, then he walked, then he actually taught again. So he's in front of people, speaking and functioning.
Okay, it just blows me away, and I think it's so fascinating. I think that's why I hold out hope and thinking, well, is there a way that we can use that kind of,
that sample, that example.
Yeah.
And we're really talking about, and Ted, I want to ask you this. So what I've heard all my life is, we only use 10% of our brain. What's the other 90% doing?
Yeah. And I think that's always been a popular thing to say. I don't think that that's true at all. I mean, the brain's doing multiple things at the same time and everything too. So, but
we just don't know enough. We know 10% of what it does, right?
Yeah. There are definitely some days where I feel like I'm not even using that much. So
that never happens to me ever.
I knew that. So that's what we do in cognitive rehabilitation. Now, with dementia, with Alzheimer's, cognitive rehabilitation techniques may not work very much because you're fighting against a progressive loss of functioning. But in the early stages, when we're not sure if this is just memory loss for whatever reason, or is this the beginning, we will do some exercises with them, teach them memory strategies, work on their ability to pay attention. We even do things with, say, I was saying earlier, normally they lose the ability to express themselves, name common objects and things like that. Use games like Scrabble and things like that are great for learning how to generate words from a letter and things like that. So
that's the practice. That's the interaction that happens.
Right. In the origins of cognitive rehab are really in traumatic brain injury and rehabbing those things. But we're using them at our clinic with people that have what we call amnestic mild neurocognitive disorder, which is the fancy term for they've got memory loss, but all their other functions, expressive language, executive functioning, things like that are all intact. Mm-hmm. So we try to strengthen their ability to pay attention. We teach memory strategies and things like that. We try to give them a little bit of hope so that, look, we don't have to, we're going to retest in a year or two to see if anything's changed and gotten worse. But in the meantime, let's not take this lying down. Let's attack this and let's teach some strategies you may be able to use.
Right. Do you do anything with music? Because I know for me, music with my mother has been like the gold standard for us. It helps me have conversations with her. It opens the door, and I know
Right.
that it's an interesting phenomenon that this she can remember every lyric to every song,
Right.
and without knowing who I am anymore.
You know,
Yeah.
it's interesting to say that we don't do anything at my clinic. However, I saw a documentary where a guy went to
Yes.
different memory care facilities
Mm-hmm.
and there were some that were so far advanced and had been almost mute for 6, 7, 8 months, hadn't really uttered a word, and they'll play some of the big band era things from the 40s or whatever, 50s and so forth, and all of a sudden they start talking and they're going, oh, I remember going to a dance with my girlfriend and we danced to this song. And all of a sudden you see these people come alive, you know. And the thing that I think probably what this is tapping into is memories that have an emotional component are very, very difficult to leave you. This is one of the problems with treating PTSD, because the memory of that trauma is emotional.
It's
Right.
imprinted. You know what? You almost said the title of it. I love that documentary. In case anybody wants to look it up, it's called Alive Inside. And there's one part of it where a woman who's literally has been in bed for the past 15 years, and her caregivers talks to her every day, but no response. And then they finally put some headphones from an iPod over her head, and you start seeing her foot
Yes.
tapping. You remember that
Yeah.
part? And
Yes.
it's gorgeous. It's a
Yeah.
gorgeous thing.
It
Yeah.
really is. And it's you can choose to do these things with them or not. And why wouldn't we? Why wouldn't we get as much life out of them as we can?
And we want them to be present as best they can for whatever their situation is as well. That's a great thing. That's what your cognitive rehabilitation is really all about, right?
Yeah, we're really trying to say that, look, the old thinking in neurology was that once an injury, always an injury. Your brain's not going to change very much. And it's just not true. While it's not technically a muscle, it does act like a muscle in the sense that the brain can be improved, it can be strengthened, and it can be taught new things. Not always,
Love that. I love that.
not always easily. I mean, when you think, if you think about just talking or remembering information, it's just automatic for you. You don't really think about the process because it just comes to you. Think about someone where now it's not an automatic process anymore. This is effortful. And those are the people we try to work with and say, hey, let's teach you a strategy. Let's practice it so much that now it becomes your new automatic.
Mm-hmm, mm-hmm.
Right.
But
Well,
it's
that's
very
the
effortful for a while.
That's the rehabilitation
Right.
we're talking about with anything.
And again, I have to reiterate that you can only do these things in the early stages. When people are later that definitely have Alzheimer's, they're not likely to pick up new information. And insurance won't allow you to work with them anyways. They won't reimburse. Right.
I see.
So
Right. When Susie asked about the music, what about the movement, like dance or some type of repetitive situation or follow the leader type of connectivity? Do you find that also is helpful?
I think anything that keeps we were talking earlier about the things that are preventative would, physical exercise is the best thing. And, as we get older, movements get more difficult and we get less coordinated and things. So definitely staying active. And if it's dancing or whatever, all good things. And you find a lot of the assisted living places have so many activities. It's incredible how many activities. I had an old couple in my office one day and I was letting them know how their test results was for the wife. And they kept looking at their watch and I said, do we need to wrap this up? And he said, well, we live down at so-and-so place, so this assisted living facility. He says, happy hour starts in about 15 minutes. And I said, well, let's wrap this up. I'll follow you.
That's awesome. I love that. I love that.
I said, I had no idea you guys had that much fun in those places.
Hey, is there any benefit to learning a new activity? Like for me, I started playing piano a couple years ago.
Right.
So it
Perfect.
becomes a challenge for me, and I,
Right.
and it's always a new challenge. Every time I sit down, it's a new challenge. So
Yeah, perfect. I'll give you a good analogy of that is if you went to the gym and your legs were very strong, but your upper body was weak. If you just went to the gym and worked out your legs, well, it's not bad for you, but you're working out an area that's already strong.
right.
You should work out the areas that are weak. It's just that we do a few things and it's difficult, and we put it away and we go back to what's easy for us. So yeah, learning to play the piano is difficult, but if you just stick with it, yeah, that's the key, is to just keep doing it. And there will be plateaus where you don't feel like you're making progress cognitively in other ways. And then if you stick with it, the brain will figure out a way to get through this if you keep at it.
It really does. It really does. And I also started I've always danced, but I started doing hip hop like 6 years ago as like kind of.
She's really very good at it.
I'm really pretty freaking good at it. I got to tell you,
and you love it.
I won a contest with my crew, and it was like, it was the same as winning an Academy Award. I couldn't have been more proud because who knew I could dance like that, right?
That's exciting.
And it becomes like that muscle gets exercised, and suddenly, like what took me forever to learn, it's like, whoa, I got it in a second now.
Well, and you have people learning a foreign language later in life. Also a great example of using an area that probably hasn't gotten a lot of use.
You were mentioning some vitamins B12 and D, and I just like, is that part of our preventative maintenance for our bodies? So we think of how to take better care of ourselves and the kind of foods we're eating when you're saying the Mediterranean diet?
Right. I don't know how preventative it is, but it's definitely all we have right now in terms of, there's been some fairly solid research showing that a Mediterranean diet has a lower rate of people developing dementia, and people that are already having memory decline that's steeper than it should be, that it's leveling off for some people. And part of that, if you think in terms of a Mediterranean diet, is just another word for less highly fat red meat and more chicken, more fish, vegetables, whole grains, less fried food, more olive oil, less butter, less animal fat, so to speak. That it's very good for the heart. Anything good for the heart's good for the brain, because the heart is sending arteries up to the brain. So anything that's clogging those or constricting them, like diabetes can do, you're not sending as much healthy oxygenated blood up there.
Right.
So no matter what, all those things are super positive. What about sleep?
I don't know of a correlation of sleep causing dementia, but you definitely see a lot of sleep disorders with people that have dementia, but also another area where there may be some overlap. We have a lot of people with sleep apnea, which a lot of people think that means disturbed sleep, but it really means it's disturbed, but it's because they're not breathing several times through the night. So they're gasping for air. And a lot of people don't know this. They just know that they feel tired all the time in the morning or throughout the day. If they have a spouse that's sleeping in the same room with them, then sometimes they'll let them know, hey, you don't breathe for sometimes 30, 45 seconds, and then you gasp for air. So these people end up with a CPAP machine, which, goes on your face. It helps you breathe. I've seen people with untreated sleep apnea for years have memory deficits. And there's a lot of research to show that the cells in the brain, they all do something different. There's different grades of them. The ones that handle memory and the ones in the front of the brain tend to be more sensitive to a loss of oxygen than the other cells. So in other words, they'll die first.
The ones that don't have enough oxygen.
Right.
Okay. So oxygen
Right.
is a huge deal.
Yeah. So sleep is very important in that respect. And if someone's telling you, look, you're gasping for air, you're snoring very heavily, things like this, go get a sleep study and just rule out that, make sure you don't have. Now, having said that, it's got to be difficult to sleep with a mask on your face, but there's actually some surgeries now that can help with people that can't or won't wear the mask as well.
Yeah.
So
it's difficult. Yeah. And it's definitely the opposite of sexy. Let's just face it.
yeah. It's
unless
not
unless masks are sexy. That's a whole other,
It could
that's
be,
a whole
if
other
you're into
fetish.
cosplay or something like that, maybe. I don't know.
I mean, you end up looking like you're in that movie Alien. Remember that movie?
Oh,
Exactly.
one of
Exactly.
You're right. That can be tough on a marriage. I would
But
imagine.
oxygen, without the oxygen, you won't be able to be here.
Yeah.
Can I ask you, what made you so passionate about Alzheimer's? What made you dig into that area of expertise?
I actually a lot back when I became a post-doctorate resident. There were less than 50 board certified route positions in the country, so there's not a lot of us. I wanted to actually work with children, and but there were probably less than 15 of those sites were pediatrics. So it just, even though I didn't initially set out to work with the elderly and to specialize in Alzheimer's, life just kept professionally kept sending me in that direction. And now I just have a huge passion for it because my stepfather died with Alzheimer's, and I live in Arizona where we have so many retirees, and I've just grown to really, the elderly are a special group to work with. They have so much to offer, and I love listening to their stories. Sometimes there's a lot of history to hear from them, and that population is growing all the time, and so we need to preserve them as much as we can. They have a lot to offer.
They're so valuable, and really, truly, I of course, champion, and my goal in this life would be to see our generations get back together, so the young have that opportunity to be around our elders, and to have that camaraderie again.
They are us very shortly.
Exactly.
Yeah,
exactly. Did you care for your stepfather?
They didn't have the money to move into assisted living, and so it kind of fell on me and my mom to do as much as we could.
Especially Alzheimer's can be a very, very, very long disease.
Right.
And it bankrupts so many people. And I've seen it happen in my own family. So I know that's also part of the reason why I'm very motivated to get the conversation out there, because like you said, the numbers are going to be up and keep growing. And we need to figure out a way where we can take care of our older generation.
It like a lot of illnesses, it touches a lot of family members because it falls on the adult children to help make decisions about
another person's
life. Do they stay in the house, or should they go to assisted living? Should they continue to drive a car, or should they not, and things like that. And those are just really tough decisions to make in their lives because it reduces their independence, which sometimes that's all they have left.
Exactly. And they want that.
Exactly.
They want to have that shred of dignity. You want them to walk with their head high in that too.
Right.
I think we're wrapping up, and I have one last question for you, if I may. Do you foresee an opportunity for us to have a cure in our lifetime?
I'm hoping so, and there's definitely a lot of emphasis on it, and it's not foreseeably going away. So we really need to keep working at it.
We'll have you back for sure, because there's so many questions we didn't get
to.
I
would love to again, and I just want to say I appreciate you guys having me on.
Oh, we're super grateful for you. Thank you. And we want to thank all of you for listening. We really hope that you liked our show. And if you did, please subscribe and share the podcast with others who are dealing with Alzheimer's.
And if you have suggestions or comments, please hit us up on social media. And
remember, love is powerful, love is contagious, and love conquers alls.
All you gotta do is sing a song. All you gotta do is sing a song.